and thanks again for the invite. We probably are unable to cover this topic to its entirety because it's quite a vast topic. So we'll do an overview of it, or the more important aspect of it. But please do ask questions if it so happens that I do not cover something that you were particularly interested in. I have no conflict of interest to declare. As mentioned by the host prior to this, it's quite an ancient disease, and this paper describes it very, very nicely. There's been evidence of chronic osteomyelitis dating back to the 16th century. Probably the oldest known evidence of osteomyelitis was described in a fractured spine in a Permian reptile. Then subsequent to that, Bromfield in 1773 termed it abscessus in the medulla because as quoted, he said there was pus pouring from the medulla. It was only in 1844 that Nelatin introduced the term osteomyelitis, which signifies that the inflammation or the infection involves both the bone and the bone marrow. Even before the advent of penicillin, which was in 1940, the principles of treating this condition followed that of Win et al., which essentially is what we stick to this day as well when it comes to surgical treatment. It is removal of all diseased tissue. Then later in the 1970s, Roll and Kikadli popularized the use of fusidine, which was quite effective at that stage. So advances have been made over the years in our understanding of this disease. However, it still is a challenging condition to treat and leads to destruction of bone and necrosis of bone. Currently, we don't have any level 1 evidence that is available for determining what is the best treatment protocol, and you'll find that these differ from institution to institution. However, the principles remain the same. And even over the past 2 decades, we've made huge advances when it comes to its treatment. The recurrence rate still remains significantly high, with some literature quoting it at as high as 25%. You will notice that these normally report on recurrence rate within 12 months of treatment. Beyond that, or even beyond 24 months, most likely the recurrence rate would be significantly higher than this number. The burden of disease is quite significant. We don't particularly have any local literature looking at this, but if we were to extrapolate from the international literature, this paper describes it very nicely. If you look at the average length of stay in hospital for patients that are being treated for chronic osteomyelitis in the UK, it is said to be about 17.3 days. And you are looking at probably a bed cost of £500 per day. These numbers are said to be slightly less and slightly improved when these patients are treated in specialist centers. A number of up to £16 million could be saved if these get treatment by a specialist in the field and in the identified early. The US literature quotes something as high as 35,000 per episode for the treatment of a patient with chronic osteomyelitis. How these come to inoculate in one's bone particularly is through direct or indirect means. What we tend to see is children versus grown-ups tend to follow a slightly different pattern. There is some cross-linking between the two, but for the most part, they follow different pattern. With kids, you get more of your hematogenous type of spread. They could have had an upper respiratory infection that settles within the metaphyseal bone, or it could have been a UTI, versus your adults. With this group particularly, we tend to see more direct trauma, which it could be from open fractures or even closed fractures that are treated by operative means. The risk of chronic osteomyelitis does exist. As far as open fractures, a local paper quoted up to 50% risk factors of developing chronic osteomyelitis. And with the management of closed fractures through surgery, this carries a risk of between 1 to 5%. A slightly different entirety to this, but quite closely linked, is the topic of periprosthetic joint infections for knees and hips. This carries a risk of chronic osteomyelitis of up to 2%. However, this significantly goes up with your revision surgeries. So in what we are largely confronted with in these treating centers, it's related to fracture-related infections, whether treated surgically or from open fractures themselves. This presents a significant risk factor, especially in grown-ups, as mentioned, not so much in kids. Kids do experience trauma, but not to the same degree. However, even this doesn't cover the picture completely, because the definition of fracture-related infection came into being in 2018. I think that the meeting as displayed in this publication was in 2017 when they decided to formalize the definition. However, it only came into use in 2018. So if you look at the published literature prior to this, this definition was not used. And because of this, it's probably underreported as to how much impact this has on chronic osteomyelitis. It uses a very similar criteria to that of the musculoskeletal infections system for periprosthetic joint infections. That changes now and then, but the principle is the same, as you would see displayed on your screen there. This algorithm is from the same paper as mentioned prior to this, that you get criteria that confirm the diagnosis of fracture-related infections, and you get that seem to suggest. So the suggestive criteria pretty much say that you need to investigate a bit more to confirm if there is infection or not. In theory, it might seem pretty much straightforward to be able to diagnose this type of infection, but in practice, it can prove to be particularly difficult, with significant waste in treating the wrong diagnosis. But this, I felt needed a particular mention because it plays a significant role into how much chronic osteomyelitis we see, especially in the public practice. With regards to pathophysiology, this is largely a coexistence of infected and non-viable tissues, not just restricted to bone, and an infective host response, as described by these two gentlemen that described it in 2000. And until you address both these factors in your management, the prospect of success a bit slim. There's a local paper that actually describes the pathophysiology quite extensively by one of the professors in Durban, Prof. Len Murray. It also speaks to the same sentiment as the last slide, excuse me. New developments have come to light since its publication. However, the principles remain the same. Like many other chronic infections, chronic osteomyelitis is a biofilm-based infection. You get less number of your planktonic or free-swimming microorganisms, and you get more of your sessile ones, which grow at a very slow pace. This particularly makes it difficult for antibiotics to be able to penetrate these microorganisms, especially because the use of antibiotics is centered around replicating microorganisms, which you don't get in this type of infection. And what you're seeing there is just, I think it's quite a well-known picture of the stages of how biofilm forms and how it matures from adhering to the surfaces that it infects, in this particular case bone, and forming microcolonies. This is all in the efforts to try and avoid whatever the host might attempt to clear the infection. And so you find nucleic acid material there, and it's surrounded by this glycocalyx polysaccharide layer that protects it from the action of antibiotics. Probably also linked to this is the concept of osteoimmunology, which has highlighted the role of osteoclast and osteoblast. This is characterized by osteolysis in combination with an effort to try and repair the bone through osteosclerosis. Now, the rank system is involved in the activation of these osteoclasts, and this causes bone loss. Unfortunately, the reparative action of osteoblast, which aims to try and contain the infection, happens at a much slower rate versus the osteoclastic activity. And if you add a compromised local environment within the soft tissues and bone, or dead bone for that matter, to this equation, the problem is compounded remarkably. And so this makes staging the host particularly important when you are engaging in treating these patients. And two gentlemen decided to actually come up with a staging system. I'm hoping that the table is clear. It's clear on my side. I'm not sure if it's clear on everyone's side. But Sheni and Meda came up with described a classification system which addresses precisely this. They divided it into the anatomic type and the physiologic type. So the anatomic type will come to in a while, but what the previous slide was speaking to is precisely the physiology of the host. And if this is not stratified, you might institute the wrong treatment for these patients. So you have to know about all these systemic illnesses or local conditions that compromise the soft tissues before you decide what type of treatment you're going for. This could range from just controlling the infection, or it could come to trying to cure the infection. So for your type A hosts, as a normal healthy host without any comorbidities, and by all means with this type of patients we aim to try and get a cure because they can withstand long terms of treatment. But when you get to your type C host, these are particularly frail patients with poorly controlled systemic comorbidities that actually the treatment, if you choose the wrong treatment, it's gonna be worse than the actual disease. So these ones, for the most part, are largely palliative. The anatomical part is probably the easier part of it because we use X-rays for this. And if you're uncertain, then we can use CT scans as well. CT scans come in very handy when you want to identify the extent of the sequestrum or the bone necrosis, and that helps you to plan going forward with your debridements. So clinically, these patients will come with bone pain particularly. So this is beyond the acute stage, because with kids, you normally get an acute osteomyelitis that might be missed or inappropriately treated or undertreated, that then subsequently goes to becoming a chronic osteomyelitis. And the presentation is slightly different. At this stage, you are unlikely to get a toxic type of patient who's pyrexial. That aligns more with your acute picture. But nonetheless, if they get an acute accumulation of pus, so it extends into joints, then they might get an acute septic arthritis, which might then present in that picture. But for the most part, this is it's at a later stage. They come with this non-healing chronic sinuses that are draining pus. They present with bone pain, and if it's close to joints, then they come with reduced range of motions of these joints. And often than not, especially with your grown-ups, you might find like old scars of previous surgeries. They might have had implants inserted and removed. By the time they get to a specialist center, sadly, they've had multiple surgeries. They might have bone exposed, but they might even have implants exposed before we get to see them. This picture that you see of the X-ray, you can see there's cloaca formation that leads to forming fistulas, or better known as sinuses, through the skin, and you see there's dead bone there within the medulla. And until that is addressed, this infection will not be controlled. I'm sure most of us will probably remember this table from undergrad when it comes to causative organisms for chronic osteomyelitis. For majority of patients, Staphylococcus aureus is the dominating organism in the cause of chronic osteomyelitis. And this is for many regions beyond just the African region. However, when it comes to infants, these ones you must be particularly careful with, because more often than not, we do see cases of multifocal osteomyelitis in the acute stages. So you need to particularly pay attention to that and actively exclude it, because they can quickly deteriorate in their physiology. When you get to the older population, Staph aureus still dominate. However, you start to see more gram-negatives, and you start to see a more polymicrobial picture. A significant number of patients, however, even with deep intra-op samples, culture no organisms, and were unable to identify the cause. I think it's up to 30%, if not more, of patients were unable to identify which organism is causing the infection. More locally in the unit, from our own experience, it's not too different from what the rest of the world and other centers within the local regions are experiencing, which is largely Staph aureus. But of particular interest is the rising number of gram-negatives that we are starting to see. The initial thinking was a link maybe between HIV and the rise in gram-negatives. However, with our study, we could not show that correlation, that it wasn't statistically significant. And looking at local data as well, that has not been the case. There is a local paper by some local colleagues in Durban as well, who looked at the microbiology of chronic osteomyelitis in our setting. This, I think, is a study from Pietermaritzburg. And what they found with gram-negatives was that they saw most patients with post-traumatic chronic osteomyelitis presenting with gram-negatives, and no association with HIV. I think for the most part, this is due to these multiple surgeries these patients have to undergo and these long hospital stays, but we couldn't see any association with HIV as mentioned. Now, when it comes to treatment particularly, and again, I hope this table is able to show that it's from work by Fantoni. So these regimens will differ from region to region, and sometimes even from institution to institution, based on the microorganisms commonly cultured and also availability. Adjustment is based on sensitivity of the results after intra-op samples. So once you've got chronic osteomyelitis, it's not an emergency. So we normally hold to using antibiotics until we have samples that we took of bone intraoperatively and we have sensitivity results and we can give directed antibiotics. Now, whether you give intravenous antibiotics or oral antibiotics, I think there's been a few studies that have shown that this has no impact on the long-term outcome for chronic osteomyelitis. And how long you give them for, the arbitrary number that we normally give is between 4 to 6 weeks. However, again, no literature seems to suggest what happens if you stop at 4 weeks or if you go beyond 6 weeks. Obviously, the burden of antibiotics in patients has to be taken into account as well. Of particular interest is the use of rifampicin. This was described a while ago. Part of the reason we add it, even with patients that have got sensitivity results, is that it's actually able to still have a bactericidal effect, even with microorganisms that are in the sessile phase. So that allows the antibiotics that works against those microorganisms to access the biofilm. And so we normally use it. We never use it as monotherapy because that has been shown not to work. So we almost use it always as an add-on therapy. When it comes to principles of surgical management, I mean, as mentioned before, there's no level 1 evidence, but we have a good idea of what works and what doesn't work. And the principle is unchanged. It's centered around these 3 points. That is resection of all necrotic tissue, dead space management, soft tissue and bone reconstruction, which we'll come to as the last part. As far as resection of all necrotic tissue is concerned, in earlier years, we might have been more conservative than we should have been when it comes to this aspect of the surgical treatment. But a lot of the work now and a lot of authors actually, beyond suggesting, are saying that we should be treating this in the same way that we treat cancer, and how particular we are about clear margins when excising cancers. So the same degree of resection and debridement of chronic osteomyelitis and dead bone is centered around the work that has been shown with cancer treatment. So if it's dead, it must go. And if it's suspicious, it must still go. Just the pictures are depicting different specimens when it comes to resection of the conditions as listed. On our left, that's chronic osteomyelitis, that's just dead bone. And then on our far right, that I think there was a 13-year-old that had osteosarcoma that we chose to do limb salvage in. So we resected the entire distal femur. And that's now the thinking, even with chronic osteomyelitis. Concerning dead space management, this is also probably one of the more important things that you have to incorporate in your management, because once you've done the debridement, you've taken the dead muscle, you've removed the dead bone, there's dead space there, and bacteria thrive in a situation like that. And as we know, like, nature will not allow a vacuum, so it will fill that up with stuff that you have no control over, and that the infection will not go away. In the unit, we largely use the Lattenbach system. We also use the cement rods and bioactive glass. We don't use antibiotic impregnated beads. The methods of dead space management are not limited to the 4 that I've listed here. There's quite a few, but I only chose these ones because it's what I'm more familiar with and what we use. This is an example of the Lattenbach system. Prof. Lattenbach was actually the head of unit at Charlotte Maxeke at VETS before he passed on, and he came up with a system. The primary aim was local antibiotic delivery into the site of the chronic osteomyelitis, and also for dead space management. What you see there is a bigger lumen tube that we insert into the canal. This is an add-on treatment, by the way. The important part is to do a thorough debridement and resection of all the tissue, and then this is the second stage prior to that. So it doesn't replace that first step. The other tube that you're seeing there by the greens, we insert into the main tube, and as depicted in the picture, then we run antibiotics through that. It works as a irrigation suction system. You see there's a Potovac bag that we use to suction all the fluid out after a desired time for the antibiotic to work, depending on what antibiotic you use. And then you run the drainage system through that 50 ml bag as you see there depicted in the picture. And because most of the work around this is based on level 4 evidence in retrospective, we've seen good results, but without any level 1 evidence. I think it's part of the reason why we don't get along very well with the infectious diseases colleagues. And here, this is just an example of what a cement rod looks like. These are also impregnated with antibiotics. In the unit and probably many other institutions, we use vancomycin because that's the one that's readily available in powder form. And it's quite effective for our local cultures. This one we fix onto a nail. We were using this one particularly for an infected hip joint. So we go and debride and resect whatever is dead. Then we replace that with an antibiotic impregnated cement. We wait until the infection is cleared. This we follow up through infection markers and if the wounds are healing. Then subsequent to that, once we're happy that the site is clear, then we can do a replacement subsequently. However, these are not also without their own complications. As you can see depicted in these x-rays, it's the same patient that we had done that ended up with the dislocation of that cement spacer. Something that we don't use in the unit, and apologies, the picture is actually from the internet because we don't use this, so it's just for demonstration purposes. These are beads. Somebody called them Genta beads. They serve the same purpose. They're impregnated with gentamicin. They are there to manage the dead space. And once we're happy that the infection is clear, then we're happy that we can start planning for how we go about union. The advantage of using this is that you don't have to take these out. Some of them, the bone can resolve. So a secondary procedure with these ones is normally not necessary. There are some older ones that you had to take out, but with more advancement, that hasn't been the case. And then the last part of this is what we call bioactive glass. This is a surface reactant. It's a mixture of glass and ceramic biomaterial. The aim of it is to try and stimulate angiogenesis for bone and other soft tissue regeneration. We also use this in the unit infrequently, however, because of the price, especially in states. I think each unit is about 5,000, if I'm not mistaken. And more often than not, you have to use more than one unit. Pincher and his colleagues then compared actually the outcomes of these different modalities of dead space management. And no other method is superior to the next. However, as described prior, I mean, there are some advantages and disadvantages with each of them. What seems to be taking popularity now is CERAMENT. Quite significantly good results, but if you look up statistical significant difference from the rest of them, it doesn't exist. What we do know, though, is that debridement alone does not work. So we do not advocate for that. And then probably the last part, which is not as important, but still important, is how then you reconstruct the bone. With the soft tissues, we involve our plastic colleagues with flaps and all those type of soft tissue reconstructions. But from our side, largely these are individualized as to what you're going to use. So it depends on patient factors, but again, also on surgeon and institution factors. I know for a fact that in the unit, we don't use circular fixators, but if you speak to your Stellenbosch group and the group in KZN, they use rings quite a lot, and there's an advantage to that. It's quite a biological instrument, very minimal soft tissue issues. The rate of pintrack sepsis is quite significantly high, but versus a huge dissection with the other options, it might actually equal out. And in patients that would require joint sacrificing procedures, you still have the options to your far right. I think for the most part, as far as the talk is concerned, that's all I wanted to share. And I want to show just 2 clinical cases. It shouldn't be long, just to demonstrate some of the difficulties that we face when treating these patients. This was a 35-year-old male that was actually referred to us last month. He had sustained an open femur fracture and was treated at the base hospital. He had undergone multiple debridements. If you look at the X-ray, it's relatively benign or a simple fracture pattern, but the grading of open fractures is an intraoperative task. And what you see on the X-ray here might actually be misleading. And this is how he was sent to us already after a few surgeries, to put it mildly, with wounds that hadn't healed, multiple draining sinuses. He had septic emboli with some of his toes dying off. So prior to them sending him to us, they had taken him for a formal debridement. And as expected, if he's got a high-grade open fracture, you have to excise everything that you think is dead. And as a result, you're going to be left with dead space, as mentioned. And so here they decided to use cement to try and clear the infection. Subsequent to that, I'm assuming they were happy that the infection is cleared. They removed the cement, but now there's this gap that you need to deal with. So we do what's called bone transport. Here you will see that on the third picture, there is a break between the two pins. That's an osteotomy site to try and move that middle segment down. It's not shown here, but they also did the same on the distal fragment. So they were actually transporting from both ends. Subsequently, you can see he was doing relatively fine. You can see quite good regenerates from that osteotomy site, both proximally and distally. The gap is closing. They're happy that there is some callus formation. They removed the external fixator, and they put in a nail to try and stabilize the regenerate. However, you can see at this point it's quite significantly osteopenic. And in my opinion, and after having seen the patient, I don't think that sepsis ever really cleared. And that nail also is not in the best position. He continued to have significantly draining wounds. His knee was stiff. We ended up having to do an amputation for him. And if you notice by the greater trochanter there, you'll see that he has a Lattenbach tube that is inserted, because we still have infection at that site that we're trying to treat. But sometimes you have to cut your losses and institute the appropriate treatment for that particular patient. The second patient is an 11-year-old male. He's a child that was accidentally kicked at school in 2021, and he developed acute osteomyelitis. Now, 10 to 30% of acute osteomyelitis will become chronic osteomyelitis. He was managed at local clinic, then transferred to Helen Joseph's. And then finally, after a few attempts, he was sent to us. What the picture is showing there is that he's got bone sticking out, dead bone sticking out, and he's got 2 sinuses. As you will see here on his X-rays, there's a significant sequestrum with the gap. So what we did for him, we took him for a formal sequestrectomy and a debridement. In this case, we used a bioactive glass to try and enhance regeneration of that segment. And we decided to use a Steinman pin just to stabilize the segment and also supplement that with the back slap. Now, in this instance, I think a circular fixator is a very viable option. One, because of stability, and it's not as invasive, and you can actually play around with it and take him up to union once it gets to that point. But that's what we did. Thank you.
1 sec. I didn't catch that. Could you try again?
Sorry about that. It's Siri.
Thank you very much, Dr. Ntombele. This was quite, very extensive. Now I understand why you said, we cannot cover this topic in entirety in one setting. It's quite a lot to take in. And I'm sure there will be a lot of questions coming through from the Q&A. From what, let me just maybe ask something before we get some of the participants to ask a question. The treatment for the chronic osteomyelitis it sounds quite specialized. And now I am wondering now, should all patients with chronic osteomyelitis be referred to the specialist center, or is there something specific that we need to watch out for and say that, no, with this patient, we are not going to win, this patient we need to refer? Second question is with the patients with acute osteomyelitis, besides their immune status, is there anything else that would make us that should raise index of suspicion that maybe this patient might go on to have a chronic infection? Are there any warning signs to look out for?
Doc, and okay, cool.
Sure, go for it. Okay. Okay, so your first question was the need to refer all the chronic osteomyelitis patients.
Yes, it was just to say that should all cases be referred, or what is the best approach to these cases? Thanks.
Look, in principle, the answer should be yes, and probably the academic response is a yes. But just thinking about the burden of the numbers that we see, and I'm certain that it's probably not even 2/3 of the patients out there. There will be those difficulties, and not everyone that we see with chronic osteomyelitis is symptomatic or needs that type of specialized treatment. Like I said, it's a chronic infection, and it has episodes where it's quiet and then it comes back. So we treat each case as an individual case. So someone that has a persistently draining sinus and has got significant changes on x-rays, they're not going to respond to just antibiotics or oral antibiotics for that matter. We use those in combination with surgery. So the long and short of it is, I'd say yes, especially if the anticipation is that they're going to need some reconstructive work, or there's an association with maybe a septic non-union. I would say yes. But again, with being cognizant of the fact that, there are huge numbers that are being sent to these centers, as is the case, and not everyone is referred even at this point. But if you are unsure, I would certainly discuss with an orthopedic surgeon and involve them in that decision making to try and avoid sending these patients at a later stage when it's far worse than it could have been. And then with respect to acute osteomyelitis complicating into chronic osteomyelitis, there are some factors, as you mentioned, with the type of host that you have, but there is no one fast answer about who is gonna go on to develop chronic osteomyelitis. If you divide them into the pediatric population and the adults, we have, because for the most part in that age group, it's from trauma, like it's post-traumatic. So the initial injury, the initial energy of the injury has a bearing on that. So for your grade 3B fractures, those patients are at a higher risk of developing chronic osteomyelitis. So we can already advise the patient that, we're going to institute treatment for this, but you're at a higher risk that it might complicate into a chronic osteomyelitis. Some of the papers describe patients that need flaps as part of the initial injury are also have been shown to have a higher risk factor of complicating into chronic osteomyelitis. With kids, some of the work that has come out locally looked at things like HIV, but that hasn't shown to be associated. If anything, about HIV, it has more to do with a high viral load, if not even the CD4 count, a high viral load versus the HIV itself or the CD4 count. So the more important thing, or the take-home message, is you need to make the diagnosis of acute osteomyelitis, especially in children, and we need to start on treatment immediately. And that's probably the best way to avoid it complicating into chronic osteomyelitis.
All right. No, thank you, Doc. That was clear. There's a couple of questions on the Q&A, mostly related to antibiotic use. I don't know if you would want to give some comments on those, or if we have time to allow some of these doctors to just ask their questions directly to you.
Yeah, sure. I see you invited some infectious disease doctors. Yeah, go.
Maybe let's start by colleagues, you may raise your hands. It's allowable. We will take your questions live. But maybe firstly, Doc, respond to rifampicin. I saw a lot of questions around the use of rifampicin, exactly the mechanism and why does it work and when to use it. In the meantime, colleagues, we would appreciate your live comments. Thanks.
Yes, maybe when you comment on rifampicin, because I also, as soon as you mentioned, there's something clicked in my mind, because I think rifampicin is also used for graft infections in vascular surgery. And sometimes they also use it like to use rifampicin coated vascular graft as a means of preventing infection. So I don't know if that can also work in orthopedics. I just got curious when I heard you talk about rifampicin.
Yeah. Okay. I think, okay, sure. Yeah. From the chronic osteomyelitis point aspect, there's been a lot of work that looks at rifampicin. Nothing is really conclusive, but we do know a few things about it. Maybe the two main characteristics when it comes to it, especially when with the treatment of staph chronic osteomyelitis, its bactericidal activity, even with staph in the sessile phase, because the struggle with chronic osteomyelitis is biofilm and the bioavailability of the antibiotics that we use to try and penetrate that biofilm for them to even take effect. But some of the studies that are out do show that even in that sessile phase of the microorganisms, the rifampicin is able to penetrate. The other point is that it also has even a high activity level for intracellular activity, which is what chronic osteomyelitis largely is and persists in this type of cells. So because it still has activity in that intracellular level, that's part of the advantage, and that's why we use it. I think at some point there was also a popular use of Bactrim. I'd have to look at that again. I'm not too certain what was that based on, but as far as rifampicin is concerned, those are the two main reasons why we use it, because it's still active even with the organisms that are in the no growth stage, and it's active it has intracellular activity. However, we don't use it as monotherapy, because normally when we choose antibiotics, it's based on our samples that we take intraoperatively. But sort of to try and nullify the biofilm, we add it so that the antibiotic that does act against those organisms has access to them. That's the logic from the orthopedic side.
I like the part
from the orthopedic side. Yeah, but I think your answer is actually similar, because even with vascular surgery for graft sepsis, it's when the staph aureus involved when rifampicin is thought to be very effective. So I think the theory is actually similar to that you've just described for orthopedics. There's also a question from Ellen. I don't know, Ellen, do you want to ask your question? She's asking about what are the options of treatment for elderly patients who do not qualify or for extensive surgery, but keep having recurrent episode of sinus and pus drainage.
Yeah, I think actually what becomes very instrumental in that is again back to the staging or the Shenian meta classification. That's very important, because you could literally kill the patient chasing chronic osteomyelitis. So you need to know your host. By the sounds of it, the elderly are normally frail. They've got multiple comorbidities. Some of them are not well controlled, and the discussion around limb ablation should be introduced quite early in those patients, because it's an actual reality for them. It might even be life-saving. What I think also the literature is starting to show now, we're also running a study in the unit to see if in fact our patients are the same. They're looking at the quality of life of chronic osteomyelitis patients versus patients who are diagnosed with malignancies, because the hypothesis is that patients with chronic osteomyelitis actually have got a poor quality of life. Like you say, with your consistently draining sinuses, smelling wounds, their sex life is that grossly affected. So all of those things have taken into consideration, and you'd find a remarkable number of patients that actually ask for an amputation rather than these multiple surgeries that prolonged hospitalization. And so in that instance, if it calls for an amputation, that's what you need to advise the patient on. But again, the patient has to be involved in the decision. They have to know the pros and cons, and you have to advise them from you having the scientific knowledge. But the decision by all means is still theirs.
Okay, see this question, I think this is a question that I like, is asking a more practical question to say, how do you differentiate chronic osteomyelitis versus acute versus chronic on X-ray? I think you explained the clinical part where most of the patients with acute osteomyelitis would be toxic, with a fever and all signs of systemic infection as compared to the chronic. But then on X-ray, what would be the differences between chronic and acute osteomyelitis?
Yeah. So, by the time you're starting to see X-ray changes, you're already moving towards, at the very least, the subacute type. You shouldn't be seeing much changes on X-ray with acute osteomyelitis. If it's missed, then maybe it's going to the subacute type. Then you, especially in children, you're starting to see like a fuzzy obliteration of the growth plate, and that's where the control X-ray of the other side is important, because then you can pick up those differences if you compare. And we have we've had cases of acute osteomyelitis being missed. The diagnosis is largely clinical, because when you do the X-ray, like I say, you won't see much. By the time you see sequestrum or a periosteal reaction, and then you're getting this new bone formation to try and conceal the infection which you see on X-ray, that's already a sign of bone necrosis, and that's already on the chronic aspect. So on the X-ray, really, especially in a child, you might see just like some obliteration or fuzziness in the growth plate. But the workhorse of the diagnosis through clinical examination, from the history, do they have a pre-existing upper respiratory tract infection? Do they have point bony tenderness? Are they febrile? Are they refusing to walk? Part, like 80% of your diagnosis comes from that side. And if you suspect it, then you have to treat it as such. You'd rather take the child to theater and drill the bone and find no pus than to miss it, because as you can see, the sequelae is quite dire.
Ladies and gentlemen, I think it's like 2 minutes before 7 now. We still have a couple of questions on the Q&A. Now I don't know whose question to pick for Dr. Ntombela to answer.
Help with this 2 minutes, Doc. Maybe if you can talk to such an old disease, no level 1 research. Is this a neglected disease? What is going on? Something is not right. Everybody asks political questions, by the way.
Yeah. Putting me on the spot. I wouldn't say neglected. The area of tumor and sepsis, even amongst orthopod, is not a very popular one, I must declare, because it's not very clean surgery. But there's a lot of research that that has gone into it. It's just that I'm not too certain as to why running clinical trials doesn't happen much with chronic osteomyelitis. There have been prospective trials that have been run. I think there's one that was looking at CERAMENT, but it's either a challenge of numbers, and research in general is quite underfunded in the country. The more Western countries, are able to produce research on a regular basis. They've got supports, they've got like departments and units dedicated to that. So for us, it's probably a problem of research in general. For us local colleagues, it's probably just an issue with the lack of drive to do research in general, and also that the specialty itself is not as popular even amongst our orthopods. But we are actually in the process of running a prospective study looking at especially the Lattenbach to see if it works or not, because now we're tired of fighting with the infectious disease doctors in the microbiology meeting that we have every Friday.
Great stuff.
Yeah.
Doc.
Yes, I wanted to ask if you can just quickly comment on Mamushala question. She's saying she's seen in their ward that cloxacillin is the #1 prescribed drug for osteomyelitis in their pediatric orthopedic ward.
Yeah.
I don't know, what's your comment about that?
It's, yeah, we still largely prescribe clox. In fact, it's our first to go to drug because it's actually its bone penetration is quite significantly good. Like its bioavailability is quite significantly good, both in IV and oral form. And considering that, especially for children, that Staph aureus is the predominant microorganism that is isolated. So clox works very well for that. So that's also what we use.
Superb. Doc, you need to come back and help us on special situations. I saw people asking about if it was a spinal osteomyelitis, would your approach be different? So yeah, we would appreciate you coming back. Maybe your closing remarks, and then Dr. Tekanang will then close the session. Thanks, Doc.
No, thanks for the invite again, and thanks for the question from the colleagues. Maybe Dr. Mawela, you can share my email with the colleagues that still have questions. I'm happy to answer where I can, and I'd be happy to come back if invited again. Absolutely.
Superb. We will do so. Dr. Machel?
All right. Yeah, no, Dr. Ntobela, I really enjoyed your talk. Well structured, well presented. I really enjoyed it. Yeah, and I've learned quite a lot about this. I was also anxious knowing that I don't know much about bones and I must come and host you. So I was a little bit anxious about that, but I really enjoyed your talk. And yeah, I think I've learned a lot from this talk, and I'm looking forward to sharing the platform again with you in the future, because I think there is still a lot of questions that colleagues have about osteomyelitis in general, not only chronic osteomyelitis. So on this note, thank you very much. Thank you everyone for attending. And